Hello everybody, I'm Dr. Refai Showkathali. I'm a consultant interventional cardiologist at Apollo Main Hospital in Chennai. I've been practicing in the United Kingdom for 14 years and moved back to India to practice in Apollo Hospital in Chennai. So I specialize in interventional cardiology, mainly focusing on advanced coronary intervention and also advanced structural intervention, including transcatheter aortic valve implantation. I did a fellowship in transcatheter aortic valve implantation in the United Kingdom for 1 year before moving to India. So here I am going to present an interesting case of a patient who underwent a complex coronary angioplasty, and the topic is going to be about mending the heart by drilling. So this is a 55-year-old gentleman who had long-standing diabetes for more than 10 years, who presented to his local hospital on 1st of July with chest pain. His ECG, as is shown here, showed significant left bundle branch block with sinus rhythm, and he was having ongoing chest pain. He was found to be having pulmonary edema on examination at the local hospital, and his troponin was elevated as expected. His echocardiogram showed severely impaired LV function involving the anterior segment of the myocardium and also in the inferior segment of the myocardium. So he was treated medically and he underwent a coronary angiogram in the local hospital, which I am showing here now. So what you can see, this is a coronary angiogram performed with a TRIG catheter, and as you can see, it's got a significant disease involving the left mainstem coronary artery. The LAD also has a significant disease with a heavily calcified segment, and also the circumflex artery has got severe disease in the mid segment. This is the cranial view showing the mid and the proximal LAD very clearly, and also the distal LAD, which is looking reasonably good when compared to the other arteries. The right coronary artery, which is not intubated properly in the other hospital, shows a occluded mid segment with a TIMI-1 flow at the distal segment of the right coronary artery. So essentially this gentleman has got significantly calcified coronary arteries with triple vessel disease. So he was shifted to our hospital for further management. On arrival to our hospital, we were found to have hyponatremia with an admission of sodium of 119. It's probably related to the diuretic we've been given in the previous hospital. He was given 3% normal saline very slowly, gently, knowing that he has got a severely impaired LV function. Slowly his hyponatremia got better. Then we had a discussion in our heart team involving the cardiothoracic surgeons, myself the interventional cardiologist, and the treating physician, and we decided that he is a very high surgical candidate due to his severe LV impairment and RV impairment, and therefore it was decided for high-risk coronary angioplasty with the intra-aortic balloon pump support, and because of the calcification, he also needed to have a rotablation, which is the drilling technique inside the coronary artery. So as I said, the rotational atherectomy or the rotablation is used in heavily calcified arteries. It's a very complex and most challenging technique in coronary intervention. It's a drilling technique with a special diamond tip burr with a speed of around 1.5 to 2 lakhs rotations per minute. This is the picture showing how the rotablation is performed inside the coronary artery. So we took him to the cath lab, and firstly, because he's got a significantly impaired LV function, he underwent an intra-aortic balloon pump through the left femoral artery with an 8 French sheath, and the IABP was implanted into the aorta. As you know, that the intra-aortic balloon pump increases the preload of the heart and decreases the afterload of the heart, functioning during improving the coronary blood flow during diastole. He also had to have a temporary pacemaker wire because of risk of having bradycardia during rotablation. Particularly in this particular case, his right coronary artery was occluded, and the plan was to do rotablation from the left mainstem into the LAD and to do angioplasty of his coronary arteries. So this is the technique of rotablation. So what we have decided to go through is to do a temporary pacemaker wire. So essentially the idea of putting a temporary pacemaker wire is to help the heart if it goes to bradycardia, which can happen during rotablation due to the embolization of the calcific material. So I put a 7 French sheath was inserted into the right femoral artery, and a 6 French EBU 3.5 guide catheter, 7 French EBU 3.5 guide catheter was used, and the rotablation was performed as you can see in the video. It's a high-speed drilling technique, removing the calcium in the coronary arteries. So once we done the rotablation, there is enough room for us to manipulate our balloons, and so we did a balloon angioplasty starting from the mid-LAD to the proximal LAD and to the left mainstem. Then we underwent stenting of the left anterior descending artery by a 3.5 by 18 millimeter stent initially, and then another. So the decision was made to do a rotablation, and the plan was to do a right femoral puncture. So he underwent a right femoral artery access with a 7 French sheath, and an EBU 3.5 guide catheter was used. Rotawire was passed very smoothly into the LAD through the left mainstem, manipulating through the calcifications. And a high-speed rotablation with a 1.5 millimeter burr was performed for the road speed of around 165 K rotations per minute, gently from the left main into the LAD, and to create a channel for the balloon to pass through. After the successful rotablation, the blood flow was much better, and the balloons were used. So a 2.5 millimeter balloon was used to predilate the LAD from the mid segment to the proximal segment of the LAD, and also to the left mainstem artery. Once we established the balloon, we had a TIMI-3 flow, and then we decided to use the intravascular ultrasound to decide on the size of the stent to be used during the stenting technique. And what it showed is the intravascular ultrasound is a 3D view of the coronary artery inside, and it helps to decide the size of the stent. So once we got the IVUS used, then we started deploying the stents. The first stent was used at a 2.75 by 38 millimeter stent, was deployed from the mid-LAD up to the proximal LAD. A next stent was deployed for overlapping the first one, with a 3 millimeter stent from the ostium of the left mainstem into the LAD at around 18 atmospheres. So this is the final result of the coronary angioplasty. He had an excellent TIMI-3 flow down the left mainstem into the LAD, and he had a fantastic results after the angioplasty. So he was sent back to coronary care unit, and the intra-aortic balloon pump was left for 48 hours and was removed after that. And in a day or two, he was mobilized to the ward, and he was discharged in 2 days' time, and he's doing remarkably well since his angioplasty. So we're planning to bring him back for his angioplasty to the right coronary artery in the next few weeks' time. And his LV function is improved up to 45% since we did the angioplasty, and he's able to walk around 4 kilometers per day. Thank you.